Welcome everyone to our project Drug-Related Emergencies, where we'll be talking about drug overdose as well as allergic reactions. Hope you enjoy!
Hi everyone, my name is Sabrina, and for our icebreaker, we're going to do a game of I Spy. So I want you to take a few seconds and see if you can spot any items you can use during an emergency. Was that enough time? Excellent. Great work everyone. We hope you enjoy our presentation and learn a ton.
A drug overdose, also called a toxic reaction, happens when too much of a drug enters the bloodstream. At these high levels, the body can't process it normally, and harmful or unwanted effects occur in specific organs.
Local anesthetic overdose reaction. Patient factors relate to the patient receiving the drug and modifying the patient's response to the normal dose of a drug. A list of those factors could be their age. Drug doses should be decreased for clients under age of 6 and over 65 years. Drug reactions can occur at either end of the age spectrum. Sex. There's no main regardance for differences between male and female, except special considerations are taken towards pregnant women. Body weight. Lack of consideration of body weight is a major cause of overdose reactions. Pathologic process. If there is any pre-existing or any disease state, it can alter the way the body will transform it. Genetics. If there is a genetic deficiency, it can lead to the blood level of the ester to be elevated at a longer than normal rate. Attitude and environment. What the client expects the drug to do influences the effect that the drug will have, or known as a placebo effect, and normal distribution curve. Drug factors are in relation to the drug and where it is being administered. These factors may include dose. With a higher dose of local anesthetic injected, the higher the peak blood level of the drug will be. Route of administration. If topical anesthetic is used or multiple intraoral injection sites are being created, that can produce an overdose reaction. Rate of injection. Careful watch on the rate of injection is needed because too rapid injection will produce higher blood level concentration, leading to overdose. Vascularity of injection site. Having greater vascularity increases the absorption rate of a drug. The oral cavity is highly vascularized and is absorbed more rapidly here than anywhere else in the body. Presence of vasoconstrictors. The use of vasoconstrictors can decrease the rate of absorption and blood flow in the area of administration. And vasoactivity.
Clinical manifestations of local anesthetic overdose. Early CNS signs can be seen as dizziness, restlessness, anxiety, tremors, blurred vision, tinnitus, numbness around mouth. The severe CNS signs are seizures, CNS depression, confusion, and coma. Cardiovascular early signs are hypertension and tachycardia, and severe includes hypotension, bradycardia, arrhythmias, cardiac arrest. Other systemic signs include nausea, vomiting, sweating, and pallor. Chemicals involved are local anesthetics like lidocaine, bupivacaine, articaine, and mepivacaine. The vasoconstrictors sometimes combine like epinephrine, which may worsen cardiovascular effects. Excessive sodium channel blockade in neurons and cardiac tissue is the cause of toxicity.
Signs and symptoms of local anesthetic overdose that would alert an emergency. In your client, you would notice confusion or apprehension. They might become talkative or overexcited, and when they do talk, they could have slurred speech or stutter. They might start to have muscle twitches and tremors in their face, their arms, and possibly their legs. They might also have repetitive and uncontrolled eye movements, and you would also see an increase in their heart rate, their blood pressure, and their respiration rate. Symptoms that the client would start to notice and say that they would feel dizzy or lightheaded. They might have a headache, ringing in their ear, and maybe blurred vision, and they can't focus on what's happening or what's being said. They might even say that their tongue or their gums feel numb or kind of weird. They might say that they have chills and they look flushed or feel really drowsy. They might be really disoriented and confused, and then eventually have a loss of consciousness.
Hello everyone, my name is Sailor, and today I'll be talking about prevention of local anesthetic. Local anesthetic systemic toxicity can be serious, but the good news is it's almost always preventable with the right steps. First, you always want to start with a good medical history.
Look for past reactions and major health problems. If you are unsure, get medical advice before giving anesthetic. Second, patient factors. Patient-related factors are those that cannot be eliminated, but if present, may involve specific modifications to dental care to prevent development of drug-related problems. Some patients are naturally more at risk, like kids, elderly, or those with health issues. Third, the drug factors are usually avoidable through proper drug selection and how the injection is done. How we give the drug matters. High doses, fast injections, or hitting the blood vessels are dangerous. Vasoconstrictors help by slowing the absorption. Fourth, don't give more than the patient needs. Base it on the body weight and lower the dose for vulnerable patients. Number 5, topicals should be applied in small, controlled amounts. Don't spread them over large areas. And lastly, the injection technique is key. Always aspirate, use proper needles, 22 to 27 gauge, and inject slowly, about 1 minute per cartridge, to avoid overdose. So, prevention means checking the patient, using safe doses, injecting carefully, and monitoring after. These steps make local anesthetic systemic toxicity very rare. Thank you.
Hi, I'm Shaylin, and I will be speaking on the management of local anesthetic systemic toxicity. In most cases, local anesthetic overdose is mild and self-limiting. Signs include anxiety, talkativeness, twitching, and increased heart rate or blood pressure, usually within 5 to 10 minutes of injection. Management starts with stopping the procedure and placing the patient in a comfortable position. Reassure them and check circulation, airway, and breathing. Oxygen may be given, and asking the patient to take deep breaths can prevent seizures. Vital signs should be monitored every 5 minutes. Anticonvulsants are rarely needed, but if symptoms progress or drugs are used, medical assistance should be called before discharge. Most patients recover fully, but treatment is usually postponed and medical evaluation may be required. A severe overdose may occur within seconds from intravascular injection or more gradually after rapid absorption or high dosage. Signs include seizures or loss of consciousness. Management involves removing the syringe, placing the patient supine with their legs elevated, and calling for emergency help immediately. The focus is on maintaining airway and breathing, giving oxygen, protecting the patient during the seizures, and monitoring vital signs closely. Most seizures resolve as the drug redistributes, but if they persist, trained providers may give IV anticonvulsants. Afterward, patients may remain drowsy with shallow breathing or low blood pressure, so ongoing monitoring and support are essential until emergency personnel take over.
Overdose from vasodepressor drugs. The use of epinephrine in local anesthetics is to prolong the duration by slowing down the rate of absorption of the drug into the bloodstream. However, there's a list of contraindications with the use of vasodepressor drugs and epinephrine retraction cords in clients with a history of cardiovascular diseases, hypothyroidism, diabetes, and in clients taking monoamino oxidase inhibitors, class of antidepressant and anti-Parkinson drugs. Ralophias, which is used in treating hypertension, and ganglionic blocking agents inhibiting transmission between preganglionic and postganglionic neurons in the ANS.
Clinical manifestations. Chemicals involved are epinephrine, adrenaline, the primary active chemical causing vasoconstriction, increased heart rate, and CNS stimulation. Local anesthetic agents, if combined, such as lidocaine or articaine, which may exacerbate severe systemic effects if absorbed in excess. Preservatives, excipients in the anesthetic solution, like sodium bisulfite or metabisulfite, may trigger sensitivity reactions in some patients but are not the main contributors to overdose manifestations.
Signs and symptoms of an epinephrine overdose that would alert a medical emergency. You would notice an increase in the blood pressure and heart rate of your client, and then they would start feeling scared, anxious, really tense and restless, kind of jittery and freaked out. They would be complaining of a headache and feeling really dizzy. They might say that they're starting to sweat and say that they have a hard time breathing and have palpitations. They would say, oh, like it feels like my heart is beating out of my chest.
I'm also going to review the key ways to prevent overdose reactions with vasoconstrictors, especially epinephrine, are used in dentistry. First, safe concentration. The optimal use of epinephrine with lidocaine is 1 to 200,000 to 1 to 250,000, which is the safest practice because it's using the lowest effective concentration. The 1 to 50,000 dilution doesn't help anesthesia. It only controls bleeding, and even then, only a small amount should be used directly at the bleeding site. Secondly, retraction cords. With epinephrine, deliver very high doses that can quickly enter the bloodstream, especially if the tissue is damaged. Safer options like ferric sulfate or aluminum salt should be used instead. And ADA guidelines. As mentioned before, Yaya talked about this in his slide. To summarize, overdose preventions mean using the lowest effective concentration, avoiding dangerous delivery methods like retraction cords, respecting ADA guidelines, and tailoring care to the patient's health.
This is the management of epinephrine overdose. Most cases of epinephrine overdoses are short-lived and don't require much intervention, but in some patients, symptoms can last longer and need some management. The common signs to look out for include anxiety, tremors, sweating, headaches, a flushed appearance, changing in heart rate, and elevated blood pressure. The first step is to always stop the procedure and remove any source of epinephrine. Next, position the patient upright or semi-seated, avoiding the fully supine position since that can make any cardiovascular effects worse. After that, check the basics: airway, breathing, and circulation, and then focus on keeping the patient calm and reassured. Anxiety tends to make symptoms worse, so using a calm and steady voice is important. Once the immediate steps are taken, monitoring is essential. Blood pressure and heart rate should be checked every 5 minutes, and they usually return gradually to baseline. If the patient has difficulty breathing, oxygen can be given, but if the reaction is severe, with very high blood pressure or neurological symptoms, medical assistance should be called right away. In persistent cases, medications may be considered, such as nitroglycerin to lower blood pressure, or beta blockers if IV access and trained personnel are available. Finally, patients should remain seated until they are stable. They often feel tired or washed out afterwards, and if symptoms persist or they have a history of heart problems, further medical evaluation or hospitalization may be required.
Overdose reaction from CNS depressant and opioid analgesic with sedation drugs. Any client that is sensitive to the average dose of the drug can be referred to as hyper-responder and would require the drug to be given. Clients that may need more of the drug to produce the minimal sedation would be more so known as hypo-responders.
Clinical manifestations of CNS depressant overdose. CNS signs are drowsiness, confusion, slurred speech, impaired coordination, dizziness, lethargy that can progress to stupor or coma. Respiratory signs are respiratory depression, slow, shallow, irregular breathing. Cardiovascular signs are hypotension and bradycardia. Neuromuscular manifestations are reduced reflexes and muscle weaknesses. Other systemic manifestations are nausea, vomiting, hypothermia, pallor, cyanosis. Among severe cases, respiratory arrest, cardiac arrest, and death can occur. The chemical involved are benzodiazepine, example diazepam or lorazepam, barbiturates, example phenobarbital, opioids, example morphine, codeine, alcohol, ethanol, and other sedative hypnotics, example zolpidem. They all act by enhancing inhibitory neurotransmission and suppressing neuronal excitability.
Signs and symptoms of CNS, depressant, and opioid analgesic drug overdose that would alert a medical emergency. For sedative hypnotics, you would notice that the client has become really drowsy and unable to keep their mouth open. They'd be very sluggish. They would have a loss of gag reflex. You would also notice shallow or rapid breathing, low blood pressure, and cold, moist skin, which is a sign of shock. For opioids, they would show signs of pinpoint pupils and slow and shallow breathing, along with a slow heart rate and blood pressure. And in severe cases, they can become cyanotic and show signs of blue lips. They could also feel cold and clammy and eventually have a loss of consciousness and eventually coma. For sedative hypnotic symptoms, the client would feel quite calm. They would move towards being tired and very sleepy and find it difficult to stay awake. They would be unable to control their body movements, and they would feel like they have really shallow or labored breathing. And for opioid symptoms, they again would also feel drowsy. They would have a euphoric feeling. They could be confused, lightheaded, and dizzy, and they could also have trouble breathing. And maybe they would say something along the lines of, "I can't catch my breath." And in some cases, they could feel nauseous as well.
Lastly, I'll outline the main strategies to help prevent overdose when using CNS depressants. Medical history first. Always check the medical history carefully. If a patient has reacted badly before, start low or use a different class of drug. Second, using safe routes. Deep sedation should never be attempted with oral or IM drugs. IV and inhalation routes always allow careful adjustment of the dose, which makes them much safer. Another point, prevention depends on the provider too. Only trained, licensed clinicians should perform sedation, and they must be ready for any complications. And lastly, patient monitoring. Because IV and inhalation drugs act quickly, patients must be monitored continuously. That way, if something happens, it can be handled right away. To summarize, prevention is about using safe routes, starting cautiously, knowing the patient, and staying alert throughout the procedure. Thank you.
When managing central nervous system depression, the first step is to stop administering the sedative hypnotic. The onset overdose symptoms depends on the route. Within minutes for IV, 10 to 30 minutes for IM, and 45 to 60 minutes for oral. Next, positioning is important. A semi-conscious or unconscious patient should be placed in a supine position with legs slightly elevated to maintain adequate cerebral blood flow. Airway and breathing must be assessed. Ensure the airway is open using a head tilt chin lift if needed. Watch and listen for breathing and monitor circulation carefully. If patient is breathing adequately, support them with oxygen. If breathing is shallow or obstructive, assist with ventilation, or rescue breathing should be provided. Use appropriate rates for adults and children. Throughout management, vital signs should be checked every 5 minutes, with pulse oximetry used if available. If blood pressure or pulse is lost, CPR must be started immediately. If trained, established IV access can be helpful, especially for treating hypertension with fluid or medication. For benzodiazepine overdose, specifically flumazenil, it can be used as an antagonist. It's given intravenously starting at 0.2 milligrams and repeated at intervals until the desired effect is reached, up to 1 milligram total. Finally, recovery and discharge require very careful monitoring. The patient must remain under observation until they regain normal breathing, blood pressure, and consciousness. In case of severe overdose, they should be stabilized and transported to hospital. Discharge is only safe once the patient can walk unaided and should always be into the care of a responsible adult.
An allergy is when the body becomes extra sensitive after being exposed to something called an allergen. If the person is exposed again, the reaction can be much stronger. In the dental office, we usually see two types. Type 1, or anaphylactic shock, which is immediate and serious, and type 4, delayed reaction, which shows up as contact dermatitis. A patient's history is a key factor in determining their risk for an allergic reaction, though the specific drug selected is equally important. If an individual is genetically predisposed to allergies, extra caution must be taken before prescribing any medications. Patients with multiple allergies, such as hay fever, asthma, or various food allergies, are far more likely to experience drug-related allergic reactions in the dental office than those with no allergy.
Clinical manifestations of allergic reactions can be seen as mild reactions, which includes hives, itching, redness, watery eyes, sneezing, nasal congestion, nausea, abdominal cramps. Severe reactions like anaphylaxis show signs of widespread hives, swelling of lips, tongue, face, severe shortness of breath, wheezing, hypotension, tachycardia, dizziness, shock, or even death. Chemicals involved are drugs like penicillin, local anesthetic, foods like nuts and shellfish, environmental allergens like pollen, dust mites, insect venoms from bee, wasp, and stings, additives like latex and sulfites. Immune system activation causes release of histamine, leukotrienes, prostaglandins, and other inflammatory mediators.
Signs and symptoms of allergic reactions that would alert a medical emergency. You would notice that the client has welts and redness of their skin. You might see that the tissue in their mouth, their tongue, back of their throat, and their nose starts to swell. And they would be coughing and wheezing. They would have really rapid breathing, and they would look very flush, and they would also be hypotensive. The client would start to complain of tingling and warm skin. They would say that they have hives and bumps, maybe a runny nose, sneezing a lot. They would become dizzy, and they would be itching and feel like their skin and the tissue are really itchy. And they would also have sometimes pretty intense cramping pain as well.
Hi everyone, my name is Haley, and today I'll be talking about preventing medical emergencies related to allergies in the dental office. First, we need to complete a detailed medical history. We should always ask about food, drug, or latex allergies along with sinus or respiratory issues. This helps us identify any known risks before treatment begins. Next, we should ask the client about their past reaction history. We need to ask the client if they know what drug caused the reaction, what symptoms occurred, whether it was immediate or delayed, and if emergency treatment or hospitalization was required. The third step is to avoid any triggering agents. Once we know the client's allergies, we must avoid those triggers and related drugs, while also double-checking for preservatives and additives that could cause a reaction. Next, we should use substitute drugs. For example, erythromycin for penicillin allergies, acetaminophen instead of aspirin or NSAIDs, and non-opioid pain relievers instead of opioids. For sulfite sensitivity, pilocaine plain or mepivacaine plain can be used, and for acrylic allergies, heat-cured acrylics are a safe alternative. We may also need to modify dental materials. Latex-free gloves should be used for latex allergies, preservative-free anesthetics for LA sensitivity, and avoiding cold-cured acrylics for acrylic allergies. The route of administration also plays a key role. Oral medications are generally safer than injections, so therefore injections should only be used when necessary, such as for local anesthetics. It is also very important to label client charts with medical alerts and record all allergy details so all providers are aware. Finally, we must always be prepared for emergencies. This means having emergency drugs on hand, including oxygen, epinephrine, antihistamines, aromatic ammonia, and anticonvulsants. Quick access to these emergency drugs can save a client's life.
When a patient reports possible allergies to local anesthesia, how we manage their care depends on the situation. For elevated procedures, we should delay treatment that requires local anesthesia until a proper allergy evaluation is done. In the meantime, procedures that don't need anesthesia can still go ahead. In an emergency, things are a little bit complicated, so there are a few options. The first is the safest approach. It is to consult a specialist who can test for allergies. Pain can be managed with oral pain relievers and infection with antibiotics until the evaluation is completed. Second, if necessary, general anesthesia can be used, though not always available in regular dental offices. Third, an injectable histamine blocker like diphenhydramine can sometimes be used as a temporary local anesthesia alternative. However, it does have side effects such as burning during injection or tissue swelling, so it usually is reserved for true emergencies when other options aren't possible. If a patient has a confirmed allergy, the approach depends on the type. If the allergy is to an ester anesthetic, we can often use an amide anesthetic, as cross allergies are rare. If the reaction was to a preservative, like a paraben, we can choose a paraben-free solution. Similar for patients with a sulfite allergy, we must select an anesthetic that does not include a vasopressor. It's important to carefully review any claims of being allergic to all local anesthetics, as many of these are misdiagnosed or the result of an overdose rather than a true allergy. Thorough evaluations can prevent unnecessary use of general anesthetics, reducing the risk, time, and cost for the patient.
Here is our summary page, which is a brief overview of everything we just went over. So we mentioned drug overdoses and allergies. A drug overdose occurs when a drug enters the circulatory system in excessive amounts, overwhelming the body's ability to process it, causing harmful effects. There are 3 types: local anesthetic overdose, epinephrine or vasoconstrictor overdose, and CNS depressant, which are sedative or opioid overdose. Now for allergies. An allergy is a heightened immune sensitivity to a specific allergen. The most common in dentistry is type 1, which is immediate, and type 4, which is delayed. Make sure to always obtain a detailed medical history and note any signs and symptoms to ensure proper protocol is followed.
I'm all done filling out my medical and dental history.
Oh, perfect.
Oh, wait, I forgot to add that I'm allergic to latex.
Oh, it's fine. I'll just add it later.
Okay, thanks.
Oh, shoot. Looks like we're out of gloves.
Taylor, where are those gloves?
Oh, looks like I found some old ones here. Hey, we didn't have any nitrile gloves.
That's fine. There's no allergies noted. So it looks like you're in for your regular cleaning. I'm just going to get started with an extra oral exam first, okay? So I'm just going to be checking your lymph. How does that feel?
Feels good.
Okay, looks like everything's good.
My lips feel a little funny.
Any swelling? Any trouble breathing?
My chest feels a little bit tight. Actually, my lips feel really funny. Something's wrong.
What's going on? Are you allergic to anything?
I'm allergic to latex.
Latex? There was nothing listed on her chart. I'm going to start the emergency protocol. Call 911.
On it.
It's okay. You're going to be okay.
Charlie, we got a medical emergency. Call 911. She's wheezing. Oxygen and epi now. Watch
911. I'm going to assess your airways and I'm going to administer oxygen, okay? Where's the DDS with the epi?
Going.
Lay your head back. Breathe in. Good.
Hey, Dr. Savage, we just have an emergency over here.
Oh, for sure. On my way. I'll be right back, okay?
What seems to be the situation?
It's a latex allergy anaphylaxis. I've assessed her airways and administered oxygen.
Okay, how long has it been?
Just a minute and a half.
Okay, I'm just gonna deliver 0.3 milligrams of IM, okay?
Go to the sky or to the thigh. Breathe. It's okay. You'll be okay. You're doing great. It's okay. You're gonna feel better soon.
We have a suspected anaphylaxis in operatory 1, epinephrine administered and oxygen in place. Patient conscious but wheezing. What's the ETA on 911?
They're on their way.
Okay, so what did we learn today? We learned how important correct charting is. It all began with a missing latex allergy that the receptionist forgot to put in the chart. Next, the hygienist failed to ask if there are any changes in their medical history. What did we do correctly, though? We recognized the symptoms of anaphylaxis, stopped all dental treatment immediately, and called 911. We assessed airways and delivered oxygen. We administered epinephrine immediately, and we documented the incident thoroughly. And most importantly, we stayed calm.
Yeah, God, yeah, that was killer.